after today's webinar and available within 2 weeks at the latest on www.hepunited.org. Thank you again for joining today's webinar. My name is Kate Morris. I'm the Senior Program Director at the Hepatitis B Foundation and Director of Hep B United. Hep B Foundation is the co-lead of Hep B United with the Association of Asian Pacific Community Health Organizations, or APSHO. Just to tell you a little bit about us before we start, we're a national coalition with a goal to address the public health challenge of hepatitis B, which is the leading cause of liver cancer and, as everyone knows, a major health disparity amongst Asian Americans and Pacific Islanders. Our goal is to support and leverage the success of our community coalitions across the U.S. To increase hepatitis B awareness, screening, vaccination, and linkage to care. We have about over 20 local coalitions or campaigns across the country currently in about 13 states. If you're interested in joining our work and partnering with us, feel free to connect with us on our website, hepunited.org. We bring to you a series of webinar trainings, and today's webinar kicks off our fall season. The purpose of today's webinars and future webinars is really to highlight priorities in the field of hepatitis B. We hope that today's webinar and future ones will provide you with new insights and tools that you can use locally and nationally. So today's webinar will be focusing on hepatitis B and healthcare provider knowledge and screening practices. I wanted to also let you know that we are doing this in collaboration with the White House Initiative on Asian Americans and Pacific Islanders. And today we're excited to present you with a discussion about barriers, model programs, and opportunities toward improving healthcare providers' knowledge and reducing hepatitis B health disparities in the API community as well as other at-risk communities. Joining us as your presenters today, we have Dr. John Ward, who is the Director of the Viral Hepatitis Program at the Centers for Disease Control and Prevention Division of Viral Hepatitis. We also have Dr. Kamala Graham, who is the Co-Director of the Viral Hepatitis Center at the Division of Infectious Diseases at Beth Israel Deaconess Medical Center. And finally, Ms. Chrissy Chung, who is the Hepatitis B Prevention Coordinator with the Santa Clara County Public Health Department. Before we get started, I wanted to review a few housekeeping items and let you know how you can participate in today's webinar. Please note that all attendees are in listen-only mode and you'll be muted during the presentations. You can submit questions at any point during the presentations by typing them in the chat box, as you can see in the lower left-hand corner of your screen. And please indicate to whom the question is directed. We'll be reviewing them as they come in, and then after everyone's presentations, we'll have an open Q&A period, and I will let you know again if, and how to do that. We will do a hand raising, and I can unmute your line if you prefer to ask a question over the phone. Okay, and if you have any audio issues with using the computer, the call-in number is right there, 323-930-0091, and the participant access code is 733-4209. And with that, we'll get started.
All attendees are muted and may unmute themselves by pressing *6.
I'll turn the meeting over to Dr. John Ward for remarks.
All attendees are muted.
Dr. Ward?
Yes, thank you very much. John Ward here. It's my pleasure to be part of the webinar and to open up the presentations with a brief overview about our testing recommendations and some of the ways we're evaluating the implementation of those and some of the issues to be addressed as we look toward the future. Have the next slide, please. First of all, we're very fortunate to have a national action plan for viral hepatitis for all forms of hepatitis. As it relates to what we're discussing today, two of the major goals are impacted by the quality of hepatitis B testing and linkage to care, where we explicitly have as a national goal increasing the proportion of persons aware of their status if they're hepatitis B infected, and also elimination of mother-to-child transmission, which an important component of that is a testing of pregnant women, as I'll show you in the next slide, please. We have a vaccine-based strategy to eliminate transmission of hepatitis B virus in the United States. The cornerstone of that vaccination strategy is vaccine-based interventions targeting the infant, beginning at the time of birth. Part of that intervention is knowledge of the mother's infection status. And so since 1988, all pregnant women, have been recommended to be tested for hepatitis B surface antigen. And if they were positive, their infant received hepatitis B vaccine within 12 hours of birth, as well as hepatitis B immune globulin. And then this is an important component of the general infant immunization recommendations we have for all newborns and infants in the country, which comprise this vaccine-based intervention. Next slide, please. And we've done a very good job of achieving high vaccination coverage. We've also done a pretty good job of achieving high coverage of testing of pregnant women. Over 90% of pregnant women are tested for hepatitis B surface antigen. And their infants, many of their infants, do receive those interventions that I just alluded to. However, we still have a problem with about 800 to 900 infants becoming infected with hepatitis B every year because of lapses in testing or because of the failures of these vaccine-based strategies. Next slide, please. One of the biggest reasons for failures of vaccine protecting the newborn from transmission is that the mother has a high viral load, and then that vaccine doesn't mount an immune response to overcome that large viral challenge. And so we are considering at CDC the value of, in addition to testing women for hepatitis B surface antigen, to go a step further, and if positive for surface antigen, to recommend testing for that woman for evidence of a high viral load, either by e-antigen testing, which is an indirect marker of viral load, or for the viral load testing directly. And that really serves two purposes. You could then perhaps use antiviral therapy in the last trimester to lower that viral load and protect that infant from infection, but also target the women who are at greatest risk for hepatitis B liver disease, so actually do something for that woman's health as well. So I just want to get that on everybody's radar screen on the call as an additional element of testing for the future. Next slide, please. The rest of testing is really seeking to identify the 700 to 1.4 million persons CDC estimates are in the United States living with hepatitis B infection. As we put out in our Institute of Medicine report some years ago, a large proportion of those persons are currently unaware of their status, and in the absence of effective care and treatment, contribute to this 3,000 deaths that happen from hepatitis B every year. Next slide, please. As we've had a successful vaccination strategy, more and more of the persons who are newly diagnosed with chronic hepatitis B are persons who were infected in other countries, most often at the time of birth or as young children, and then have immigrated to the United States thereafter. And that just shows you this trend over time. Next slide, please. So this represents a major health disparity, particularly for Asian Americans, because most countries in Asia have a very high prevalence of hepatitis B, because vaccination programs have started relatively recently in those countries. So you have a large proportion of the population living with chronic hepatitis B. And as you can see here, we estimate that almost 2/3 of all Asian Americans are foreign-born. They represent 50% of hepatitis B cases reported to CDC. because hepatitis B is a major risk for hepatocellular carcinoma in later years, this is a major health disparity for Asian Americans. It's borne out in a high mortality from hepatitis B compared to whites, and then we estimate that this burden grows because about 50,000 persons migrate to the U.S. every year who are already hepatitis B infected, particularly from China, Vietnam, and the Philippines, representing the lion's share of this infected population. Next slide, please. We've also looked at refugees. CDC is responsible for refugee health in the United States. This paper just came out several weeks ago showing the high prevalence of hepatitis B infection among persons from Burma, people from the Hmong tribesmen from the hill country of Vietnam and Laos, and Somalia. Next slide, please. So this is really the basis for CDC's recommendation that was released in 2008, recommending hepatitis B testing for all persons born in countries that had a high endemicity, which we defined as 2% or greater. That's most countries in Asia and Africa, and a few other countries in Eastern Europe, the Amazon area of South America, and a few other places. This screening, we've shown it to be cost-effective, and most importantly, the U.S. Preventive Services Task Force joined with CDC in recommending this strategy just earlier this summer. And that's important, as many on the call know, because that provides a way to pay for testing through the Affordable Care Act. So removing cost as a barrier to testing. Next slide, please. For those who are in care. If I can have the next slide. So we begin to monitor how many persons are reporting being tested. This is a study that was published last year based on the REACH survey that targets racial and ethnic minority communities. And as you can see here, for Asian Pacific Islanders, about 43% reported being tested for hepatitis B, 13% reported being infected. So a very high rate of both testing and of knowledge of infection. So that was, in some ways, good to see, although we would like that proportion to be higher. Next slide, please. As far as knowledge of being tested. This just gives you a variety of socioeconomic indicators for testing. I felt like the one that was most interesting was the large differential regarding whether you had health insurance or not. So again, access to care is an important predictor of access to quality preventive services. It's something that we all have to work on. And I think this linkage to care bears out in another study I'll show you in the next slide. Actually, the slide after this, but this is a series of demonstration projects that we conducted over the last 1 to 2 years, targeting communities, Asian Americans and African-born persons, and testing them for hepatitis B. And as you can see here, the prevalence of surface antigen range from about 3% to almost 10% in these populations, showing that the prevalence is indeed high and that testing is warranted for these communities. Next slide, please. However, the challenge is that while you can successfully implement testing and have people agree to testing and define people who are infected, the big challenge is to then link them to care. As you can see, the receipt of test results was quite good. Counseling them about what that meant to their health was good. Where the fall down comes is actually getting that person linked into care and having that first visit received by that patient. And so we actually are building on this knowledge and have just funded 3 new project areas to see how we can strengthen this linkage to care for Asian American communities in New Jersey, Chicago, and Sacramento. Next slide, please. So in summary, hepatitis B is a major health disparity for Asian Americans. CDC and the U.S. Preventive Services Task Force recommendations guide HBV testing in the United States for pregnant women, persons born in endemic countries, and other at-risk adults. The prevalence of hepatitis B is high among populations recommended for testing, and what we need to focus on now is building the capacity necessary to increase the proportion of hepatitis B infected persons who are tested, aware of their status, and successfully linked to care. Thank you.
Thank you so much, Dr. Ward. That was a great intro to today's topic, and also for folks that were really unfamiliar with the disease itself. As a reminder, if you have any questions at any point during the presentations, please feel free to submit them in the chat box in your lower left-hand corner, and we will address them at the end of the presentations. Our next speaker is Ms. Chrissy Chung from the Santa Clara County Public Health Department. Chrissy will talk a little bit about a specific study that was conducted by the Asian Liver Center at Stanford University, looking specifically about provider knowledge amongst a certain provider population in the Bay Area, I believe. And then we'll move on, and she'll introduce to us to some barriers, and then we'll move on to Dr. Graham, who will talk a little bit about some new solutions to our breakthroughs and practices in provider screening. So I'll turn it over to Chrissy.
Thank you, Kate. Thank you for the opportunity to present after Dr. John Ward, no less. So again, my name is Chrissy, and I am currently the Hepatitis B Prevention Coordinator for the Santa Clara County Public Health Department. And we do believe that this is the first position at the county level that focuses specifically on hepatitis B, so we're very excited about that. And if it's not true, somebody on this call hopefully can correct me. But anyways, the presentation and the work I'm going to talk about today was actually work done at the Asian Liver Center. I was previously the Perinatal Research Coordinator, and I just transitioned out of that position this year, but I still work and collaborate very closely with my colleagues at the Asian Liver Center. So a little bit about the Asian Liver Center. It was the first nonprofit in the U.S. Established to address disproportionately high incidence of hepatitis B and liver cancer in APIs by Dr. Sam Stowe. And really the goal is just to eradicate hepatitis B and reduce incidence and mortality of liver cancer worldwide. And we did this with a four-pronged approach, which is established under the acronym of CARE, which is collaboration, advocacy, research, and education and outreach. And we have currently the Asian Liver Center is making a really big push towards social media. So if you can see at the bottom right-hand corner, it's our hashtag. So it's hashtag #JoinJade, which refers to the Jade Ribbon campaign. So you can look it up on Instagram, on Twitter, and also on Facebook. So during my time at the Asian Liver Center, I managed Hep B Moms, which was the perinatal prevention branch, and it was through Hep B Moms and a translational grant from the CDC that I was able to do this research. So we currently have 2 published studies focused on hepatitis B knowledge and practice of providers in Santa Clara County, which is in the San Francisco Bay Area of California, and we're currently working on a 3rd. So I will actually touch upon the 2 studies very quickly. The first is a quantitative study where we looked at the levels of knowledge in for hepatitis B and preventive practices among perinatal nurses. So we really wanted to assess, what are the current levels of knowledge and what are the clinical practices related to hepatitis B among perinatal nurses. And this includes nurses at the OB's office, who are in the NICU, who are labor delivery, and in the well baby nurseries, just surrounding delivery. And we wanted to look at what it looked like in a U.S. population that is at high risk of chronic hepatitis B in Santa Clara County, where there's a large API population. And our study was a cross-sectional study in Santa Clara County. There was an 18 question multiple choice question survey, and we looked at current hepatitis B practices and knowledge. And after the pre-survey, we did an educational intervention in the form of a seminar. And after the seminar, we did a quick post-survey that also looked at, asked questions about future practices for hepatitis B and also retested the knowledge of hepatitis B that was hopefully learned in the seminar. So we excluded nurses who omitted more than half the questions in the given survey section. And the reason for this is if we happen to run out of time and we weren't able to administer the surveys, we actually prioritized the education over the survey because really having time to educate nurses in these busy practices is very precious. So we definitely wanted to make sure that we're able to properly educate the nurses. So the nurse education was provided at either hospital-wide nurse competency trainings or skills days, or during weekly staff meetings, or during seminars in between nursing shifts. So during this time period, we actually did 81 sessions, educational sessions on 31 separate days. So it really was, you know, wherever we could get in time and schedule time at these different hospitals and with these different departments, we just got in wherever we could. So that's why the education in the seminars really varied from hospital to hospital. And the nurse demographics that we looked at, we actually surveyed and did seminars and educated 518 nurses, 99% female, and in terms of the ethnicity, we had 42% API and 37% non-Hispanic white. And as far as the experience, it was a wide range. So the range of experience of these nurses reported was anywhere from 20 to 69 years of nursing experience, with the mean and median being 44 years. So it's a decent amount of years and experience that we saw in the nurses that we surveyed. So the results are for the practice survey. You guys can see in the slides. So the first question, it shows that the majority of the nurses actually had experience with a hepatitis B, with an HBsAg positive pregnant woman. So it really wasn't just, well, I've never seen a woman, so I really don't know what to do. So that was a good indicator of most of these nurses had this experience. The one that really concerned us the most was question number 2, where we asked you routinely provide educational information about Hep B to HBsAg positive pregnant women. And only 51% of these nurses say that they do. So, you know, really, if you think about it, you know, where else are they going to get this educational information other than, you know, they'll go online, they'll ask their friends, but only 51% of these providers said that they did. Number 3, only 17% had routinely advised HBsAg positive pregnant women to be referred to care. And questions 4 through 7 asked about vaccination and prevention for their newborns. 4 and 5 ask about whether or not nurses routinely inform their women that it is very important to get the birth dose and HBIG within 12 hours. So only about 3/4 of the nurses said that they did. So there was still a good number of nurses who did not. And then 6 and 7, questions 6 and 7 asked about the second and third dose, and also asked about post-vaccine serology testing. Are these nurses telling their patients about the importance of these? So you can see that it dwindles down from 60 to 19%. So only 19% mentioned that it was important to get post-vaccine serology testing for their newborns who are at risk. So anecdotally, we really found that many of the perinatal nurses felt this was not a responsibility, and it really fell to the responsibility of the pediatrician's office. So that's why really we saw the low numbers there. And then only 34% routinely advised them to get their household and sexual contact tested. And we had a knowledge survey of these 5 simple questions. Most of the nurses knew that hepatitis B can lead to liver cancer, liver disease, premature death, and cirrhosis. But question number 2, only 14% knew that 1 in 10 foreign-born APIs have chronic hepatitis B. So they really didn't know about the high prevalence in the API population. And question number 3, only 16% knew that if a newborn was infected with Hep B at birth, there was a 90% chance of developing chronic infection. So they really don't know the long-term consequences of hepatitis B and not preventing this at birth. Nor did they know about the severity of those consequences. As you can see in question number 5, without appropriate monitoring or treatment, what are the chances a person will die from chronic Hep B, which is 1 in 4. So really only 26% of nurses knew that. And question number 4, only 22% knew that most people with chronic hepatitis B are actually asymptomatic. So you may think, well, maybe it's because nurses are not as well equipped or well trained in nursing school to do this education. Well, we also looked at obstetrician knowledge in our study, and this data here actually has not been published yet, but I just wanted to kind of set up a comparison. So you can see the blue boxes was the nurse knowledge that you saw on the previous slide, and the pinkish box in the second column is actually OB knowledge. So you can see that really the only question that the providers scored significantly better was question number 3, if a newborn is infected at birth. 90%, they have 90% chance of developing chronic infection. So it's not really just the nurses, also with the obstetricians and the doctors are also have low levels of knowledge. So back to the nurse data. So as I said, we had also done a post-seminar survey where we asked the same 5 questions of the nurses immediately after we did the educational seminar. So the difference between the pre-test and the post-test, as you can see in the slide, was statistically significant. And we know that this only measures very short-term knowledge changes, but it really showed us that the nurses were ready and willing to learn. So like I said, another thing that we found was pre-seminar knowledge was not associated with pre-existing preventive clinical practices, and really the change in knowledge didn't significantly vary between nurses who reported following and not following Hep B preventive practices. So what this means is that just because nurses reported scored higher on the knowledge questions, it didn't always correlate to better clinical practice. And also, the third point, there's nearly all nurses reported that they would educate all foreign-born API patients about chronic hepatitis B. Out of the 414 nurses that answered this question, we had only 2 nurses that said no, and 1 nurse responded was because that the physician will get mad. So we're not really sure what that meant, and we weren't able to actually follow that nurse until later. And the second nurse said no because she said, I will educate all patients and not just API patients, which is great. And also all nurses said that they would provide educational materials, and all nurses reported that it was a useful session. So as a result, we found, and we kind of already knew, there was a low level of existing hepatitis B-related knowledge in clinical practice among perinatal nurses. And we wanted to find out more. So as we did this research, it expanded into a qualitative study. And we really wanted to do this qualitative study to really better understand the barriers and to investigate reasons for poor knowledge and delivery of education, specifically with the providers here in Santa Clara County. So in this study was in Santa Clara County. It was semi-structured, and we did face-to-face interviews with 33 obstetricians and perinatal nurses. So these interviews were transcribed, and the data was coded and organized and developed into themes. So really, among all of these 33 interviews, there was a very consistent, there were very consistent themes that showed up in all of them. And you can see them here in the next slide. The 3 themes were lack of self-efficacy, patient cues, and environmental factors. So lack of self-efficacy, really we saw from the providers that they really didn't feel that they were well trained in medical school or nursing school, or they had poor hepatitis B knowledge, and they really didn't feel they could properly educate their patients, or that really they didn't have the materials to give to their patients. So we actually also collected some quotes, and they are in the article, but I'll read one of them to you. One participant and said, and I quote, "I don't really remember being ever taught that hepatitis B was such a huge public health threat. We were never told that it was so much more widespread than HIV/AIDS, and we never knew that so many people had it. If anything, I just remember being taught how infectious it was and how easy it was for healthcare providers to get it if they weren't vaccinated. It was as if hepatitis B was only a threat for healthcare providers. So, really, for this participant, hepatitis B was not discussed in the context of racial health disparities. And the second one is stigma. Second one is patient cues. So there really was patient apathy, stigma, really preferential concern over short-term health issues such as how do I bathe my child, how do I breastfeed my child, and also doubt about efficacy of patient education. So in terms of stigma, one participant responded, she didn't want me to talk about it in front of her husband, referring to a patient, because she was scared of the mother-in-law. So I tried to be discreet, but it was hard to talk about it when she didn't even want to hear it. So really there's a lot of cultural barriers to educating the patient. And the third was environmental factors. So we know that providers have a huge lack of time. There's so many things on their plate, and there's so many things that they need to talk about. And there's a lack of resources. Providers or participants talked about failures in the system and also the importance of accurate and culturally appropriate educational resources. So one of the quotes about failures in the system was, I know that an HMO keeps these asthma registries, and every time their patients need to go in for a checkup, the HMO calls them. Couldn't the government or insurance company do the same thing for Hep B vaccines or the 6-month visit for people with hepatitis B? So, there was really a kind of a lot going on, and it was actually really interesting to kind of look at the responses from the providers and how it really fell under these 3 themes. So, let's see. So, as for summary, there was a low existing level of Hep B knowledge and clinical practice among the providers that we looked at, and as always, effective education and training efforts are needed. The paper talks about some institutional changes within government, hospitals, and insurance companies that may serve to improve hepatitis B prevention. But, what we found really is that improved provider education and training should really be supplemented by Hep B-related education and awareness campaigns targeted towards these at-risk populations. And I think that this really is where organizations and coalitions like Hep B Free and Hep B United come in and are very important. And work in provider education needs to be supplemented by all the work that our partners are doing in the community. So we're really glad and appreciative of the partners that we have and the people that are on this phone call that are really working on that together with us. And this is just an example of one of the pieces for provider awareness. And it has been published in the New England Journal of Medicine a handful of times. And really, we want hepatitis B to be a vital sign for Asian Americans to make sure that everyone is screened and vaccinated. And that is all. Thank you very much.
Thanks so much, Chrissy. Absolutely. It seems to be, it was really interesting find from it. It seems to be a very complicated issue and requires multiple stakeholders who need to join in this effort. We had a question to connect with Chrissy, and her email address is right there. If you would like to take it down, feel free to send her an email. And we'll move on to our next presenter, Dr. Kamala Graham. And Cami, I'll turn the meeting over to you.
Okay, thanks a lot. So you just heard that there are a lot of barriers to getting people tested and linked into care, and that provider knowledge is one of the barriers. And HHS's Viral Hepatitis Action Plan demonstrated the same thing, not just for maternal fetal health providers, but every healthcare segment fails in terms of knowledge and adequate information to patients. And so what I'm going to talk about today is an example of using an electronic health medical record system to attempt to overcome some of these barriers through automating this process. And just give you a little bit of background, Care Group is a network of academic hospitals, community health centers and private practices that encompasses about 5,500 clinicians and over 1 million patients, mostly in eastern Massachusetts. So it's not possible really to individually educate each person. So this was an attempt to try to create a broader program, and it is an in-progress situation I'm describing here. Next slide. No disclosures. Next slide. So the example we're using for hepatitis B sort of builds from some of the success we had in creating a hepatitis C prompt in our electronic medical record. And I'm showing here the first 10 months of the prompt implementation, where compared to the modest increase in testing that we got once the CDC put out guidelines that clarified who to test, and there was a lot of education and media outreach and all this. In comparison, when we instituted an electronic prompt, we immediately tripled the number of baby boomers that were tested each month. And so we were looking at trying to replicate that for hepatitis B. Next slide. And I want to just talk a little bit about how to operationalize implementing a prompt in electronic medical records, because I'm assuming that everyone on this call either is a champion or could be a champion. So that's the appeal here, is either identify a champion or just step up and be a champion yourself. If you're not a clinician inside a particular healthcare system that you're interested in working with, you do need to find a clinician that's inside, because every health system is different in terms of how they're structured. And in partnership, if you're from outside the health system, you're going to work to create a team of stakeholders. And what we have for hepatitis B that I think is a nice cross-section of folks is people from primary care, hepatology, infectious disease, clinical pathology, because they need to ramp up their testing programs, the IT or EMR people, database, and the administration needs to have buy-in that this is an important initiative. We've already heard from Christy the importance of simple educational materials for both patients and providers, and the CDC and advocacy materials are really what you can rely on for that. And then creating template best practice code or configurations for the EMR team that would actually implement the prompt is really, really helpful and can save you a lot of time. And then there needs to be a presentation to a committee, because there's always an approval committee that approve these types of initiatives. And that is also where you identify where the prompt will occur, knowing that health centers or health system patient flow and best points for intervention. And I want to say that NVHR, National Viral Hepatitis Roundtable, has a bunch of examples of hepatitis C screening programs that could be adapted to hepatitis B. Next slide. So the first thing you need to think about within your electronic medical record is which high prevalence factors are searchable, actionable data points in your electronic medical record. And that's actually a little bit of a subtle problem to figure out. And I'll say for our electronic medical records, we had a lot of information that was embedded in notes or free text or other very difficult to search data elements. So we attempted to focus on individuals born in high and intermediate areas as sort of the largest and most critical group of folks to find. Next slide. And one thing that's important to do is educate people so you get some degree of acceptance and buy-in that this is important. And so we did some educating using this that's very familiar to you all about areas that are high prevalence. And what we were initially trying to do within our EMR was just identify country of birth. Unfortunately, that turned out to be a free text field, and so somebody could be from Laos, they could be Laotian, it could be misspelled, and that ended up being very difficult to identify. So the IT recognized that was silly, and they are creating a drop-down menu so everybody who was born in a particular country will all get it identified in the same way. That's going to take about a year to fully implement. So what I'm talking about now is a bridge program we're trying to identify. So next slide. And so the next slide is a sort of a more difficult to interpret graphic representation of the data that Dr. Ward already presented today, which just emphasizes that you have to find international populations if you're going to really tackle hepatitis B in a community. Next slide. So one thing we initially tried to do was look at self-identified race and whether there were associations with higher prevalence of hepatitis B. And I think no surprise, people who self-identified as Asian race had a 10 to 15-fold higher prevalence of hepatitis B as people who self-identified as Black or African American, Hispanic, or white. This was more just an exercise, but almost 1 million people in the database didn't have racial ethnic designation. So then we moved on to the next attempt at identifying folks. Go to the next slide, please. So the next slide is going to show one thing that we always do capture in our EMR, and I think most hospital systems would, is the language patients prefer for their medical interview. And this is often used to trigger the need for interpreter services. And so we looked at the top 16 languages in our system and the prevalence of already diagnosed hepatitis B within those language groups. And in that top 10, 6 of the languages represent Asian Pacific Islander countries. But you'll notice that 4 of the top 10 languages represent Haiti or West Africa. So when you're working with a community, you kind of have to figure out within that community, what are the dominant international populations in your community? What are the hepatitis B prevalence rates? And how are you going to reach all of those? And so we are working on programs now specifically for Haitian Creole and French-speaking West Africans. Next slide. And so if you sort of analyze now people who've recently been seen at Bethesda Deaconess who are diagnosed with hepatitis B, looking at these top 10 languages captures about 58% of the patients who have hepatitis B. And that is going to be our initial strategy going forward. Next slide. So this is going to be a lot of detail on the next few slides, but these slides are available for reference, and I do want to emphasize these are a work in progress. I can get the next slide here. But once you decide you want to do a screening program, you have to figure out exactly what you're going to test and how to work with laboratory services, whether it's a commercial lab or an internal lab like we have. And I would say I think it would benefit all of us to have a little bit more guidance from the CDC about the the benefits of different screening strategies, because as I've done sort of a national survey, and I probably talked to some of you on this call today, there are different ways people have tried to implement this, and I'm not exactly sure what the best practice strategy is. But we're focusing on initially identifying people who have been tested, who have not been tested for surface antigen, and then trying to identify two populations of people. One, people who have true chronic hepatitis B infection and need to be linked to further services, and then people who've never been exposed to hepatitis B and need to be vaccinated. And that's what this algorithm is describing. Next slide. What this particular algorithm also does is try to eliminate duplicate or unnecessary testing to try to minimize cost to the system. This is an example. We have an ability to link educational material to prompts. And so as somebody is engaging in a medical interaction, at that point of care, they can access educational material. So this is our initial draft of a two-page educational material for healthcare providers to remind them how to interpret serologies, groups to be tested, initial follow-up tests that would be helpful. Next slide. And a very high-level treatment algorithm that I think was initially introduced to by Joan Block, but this is the most simple way of thinking about how to stratify risk groups for need for antiviral treatment. And so just trying to create a very high-level educational piece. Next slide. So I do want to say we have ongoing questions at Beth Israel Deaconess, and one is that the algorithm that I showed you will miss people who are isolated hepatitis B core antibody positive. I think that there are a couple of main risks. One is that you may be vaccinating someone who was actually previously exposed, and the other is you might fail to monitor somebody who's on immunosuppression. And so we're looking at the implications of those potential risks. And then this is our first foray with international populations, and we're also looking at other ways of digging other higher prevalence populations out of our EMR to try to implement prompts to identify them as well for testing. Next slide. So I think when you think about say a program like this in an academic health center who maybe reaches out to primary care practices and community health centers, just to remind you, there are all sorts of other groups that are important to work with as you're developing a community approach to hepatitis B, including insurance companies, so you make sure that the testing does get paid for and that people have access to treatment once they are identified. Next slide. And the Hep B United folks wanted me to just say one brief word about the importance of making sure that you've got providers where patients are, as opposed to trying to make patients come to where the providers are. And this is especially important in more rural areas, but we have large international populations in the North Shore area, for example, in Boston, who don't want to come into Boston because it's terrible and the traffic and the expensive parking. So we do telemedicine. We've got primary care doctors who have some initial educational support, but when they identify patients that they'd like to keep in their health center, their medical home, but can use telemedicine with us at Beth Israel Deaconess, that we can provide them detailed protocols, detailed support materials. We can provide didactic sessions for more complicated topics and latest data, especially after conferences, and then provide case discussion. And then also identify patient or patients who are extremely complicated or perhaps might benefit from a clinical trial, or who unfortunately have already developed complications such as liver cancer and need to be referred into to an academic center for tertiary care. Next slide. So, and I guess that was it for me.
Great. Thank you, Cami. Sorry, there was a little bit of a delay in the slide advancement. All right, and now we will open it up for questions. As a reminder, please feel free to use the chat box at the lower left-hand corner to submit your questions to the presenters and direct to whom the question is for. One of our first questions, and I think any one of our presenters may be able to answer, and I'll turn to Dr. Ward actually first, is what is the approximate cost of testing? This is a general question, testing for hepatitis B.
Well, it varies by the site and the type of testing, whether you do a whole panel or whether you do a single test. So I've heard ranges between $3 to upwards to $20. I think it's important. What we like to contrast the cost of testing now, which used to be a very big issue, but the cost of testing for hepatitis B is less than for testing for hepatitis C, for example, and the cost of testing is a minor cost relative to the to the cost saved in averting severe liver disease from hepatitis B in future years, and that's why it's important to always balance the cost with the benefits of testing and linkage to care. And when you do that, you find that this intervention is a very cost-effective intervention.
Right, thank you. Cami or Chrissy, do you have any perspectives on testing costs?
Yeah, I can comment. So the test itself, as Dr. Ward said, is cheap. A surface antigen test is about $5 to run. Now, how much is actually charged to the patient or to the insurance company is a completely different thing. But if you were doing a screening program, you should be able to negotiate either with a central lab, Department of Public Health, or other testing facility for reasonably priced testing.
Okay. All right, and our second question is directed to Chrissy. What was the OB post-test comparison for the study?
The post-test for the OBs actually looked very similar to the nurse post-test, where they all scored very high. But again, like I said, it really was given pretty much immediately after the seminar, so it's just a measure of very short-term changes in knowledge.
And then for Cami, someone had a question of what OMR stood for. I think you had it in one of your slides when you were looking at self-reporting.
Oh yeah, so OMR is online medical record. It's what we call our electronic medical record system. These were slides I actually used to try to convince our approval committee that we should implement a hepatitis B screening program. So you're seeing in internal lingo, and I apologize for that.
Great, thank you. I just want to go back to Dr. Ward. You had mentioned a new grant from the CDC and focusing on linkage to care as one component. Just can you expand on that a little and sort of how you see the focus of that grant and how it is intended to improve provider knowledge and screening?
Sure. Well, as I mentioned, we are funding sites in the greater New York City area, New Jersey, Chicago, and Sacramento, and and in contrast to the studies that I showed the results of, where we did have linkage to care as an element of that, It was really about, learning how to develop community partnerships, finding the right venues for testing where people felt comfortable to accept testing. And the weakest link was that identifying providers that would then take the person, not yet a patient, who was hepatitis B infected. So what we sought to do in the new demonstration projects that just got funded in the last week or so is to identify those care providers, up front. So you really are striving to have a much stronger continuum of care, beginning with that offer of testing, and then providing that linkage to care and treatment. And we obviously hope that will improve services for these three areas, but then we also hope that we will build a body of experience that we can share with others. And so even if we're not able to provide funding for them, at least by sharing those experiences, they can open up some new avenues for strengthening testing and linkage to care.
Great. And just to, while we're waiting for more questions to come, just to leave some last thoughts from all of you. We talked a little bit about how there are issues with lack of provider knowledge. I know that's one of the main goals nationally from HHS to address that. And Chrissy's presentation showed sort of the breadth of that and the complication of different stakeholders interacting, including institutions, patients themselves with stigma, especially in this population, and even in the provider education when it comes to medical school, perhaps, of what their perception of hepatitis B is and who's affected. What are your thoughts on what the future looks like? How do you see this playing out, especially with the healthcare system changing and with the new USPSTF recommendations that both Cami and Dr. Cami, I think you have mentioned? Do you see an improvement? Are there, how do we overcome some of these barriers? We can start with Cami.
Yeah, well, I think as I've made clear, I really believe that providing electronic medical records support complemented by education and awareness programs is going to be the way forward. In Massachusetts, because we have what you guys call Obamacare, that's been there since 2006, we're 99% insured, and we have a fairly robust health system for undocumented populations as well. So pretty much people get access to care. And so what we were able to see is the ongoing gulf that exists isn't necessarily health insurance, it's more the public health system defects that have to be addressed. So, health insurance is not public health. And so I think figuring out ways to, as we have ACA in meaningful use, most healthcare systems will have to use electronic medical records, and trying to get some of the large providers to help integrate hepatitis B reminders and maybe algorithms for steps for care, especially around perinatal, so those steps don't fall through the cracks, is going to be critical.
Right. And Chrissy?
I definitely agree with what Cami said. We're really looking forward to just kind of the changes in development. I think that making Hep B care and kind of these prompts in their electronic medical records and really building it into a part of the infrastructure is going to be really important, because we want to make it so that doctors don't have to think about it. So I think that is an important component. But definitely moving forward, because Hep B really affects such a unique population in terms of culturally, racially, and ethnically, really the cooperation and kind of the partnership of community organizations, and really still needing to raise awareness and education is also going to be another important piece of it.
Right. And Dr. Ward, what are your thoughts, parting thoughts?
Well, Well, I think we're in a much better place than we were just several years ago. I think the USPSTF recommendation for for broader hepatitis B testing beyond just pregnant women is a huge opportunity. As Cammie will tell you, health systems prioritize what the USPSTF states is important through their recommendations, and I think having this hepatitis B recommendation essentially endorsed by the task force it helps you get in the door and to make some changes within the health system. As Cammie brought out, though, that said, it's important to really cultivate local champions, and I think they're out there. And Cammie is an excellent example of a local champion, and great things can happen. So I think one of the challenges of everybody on the call, if they're a champion, great. Try to build others, in your communities, and I think that's one of the the big changes. One of the big champions we all had was Dr. Howard Koh when he was serving as Assistant Secretary of Health before he stepped down just a couple of months ago. And one of the reasons he was, as he said, was because of his heritage as a Korean American. And we have an expanding population of Asian Americans, and more of those are in health fields. And I think tapping them, because of this because of their heritage and their connection with hepatitis B is just one example of an opportunity where you can bring together a policy change with these building champions to really expand access to testing throughout the country.
Yes, exactly. And we have actually a comment come in from New York, just to wrap this up, that provider education is not enough. There needs to be systems change and political will, and I think that you really did just, emphasize that point. There needs to be a champion and multiple factors. Last question, we'll take just one more before we close out. New York State now allows to screen for hepatitis C. There was, I think, recent legislation that was passed, and the question is, what can we do for hepatitis B to have this movement? Anyone want to take that?
I'll pipe in. So, the simplicity of a one-time blood test based on year of birth, which every medical record has, I'm not sure there's many other screening programs that can be that simple. And from an
sorry, Cammie, I just want to emphasize that New York State allows nurses to screen her for hepatitis C. That was the specific question. So I think she's saying more than healthcare providers, more than the
nurses. Sorry. Okay.
Yeah. Sorry. So yes, the question was, did you want to take that?
I think Chrissy's better.
Okay.
Sorry.
Yes, Chrissy.
I actually am not sure how to answer that. I think that definitely hepatitis, our partners in hepatitis C have actually done a very good job in being very vocal and advocating for a lot of these things and the changes in the system. So I think that we can definitely take some cues from our friends working in Hep C advocacy. But, in terms of what can we do, I'm actually not sure how to answer that.
Yeah, I think you're right. There has been there's a lot of activity in terms of advocacy in the hepatitis C world, and maybe the solution is that we need to garner more voices in the hepatitis B, especially in the legislative arena and advocacy movement. So just to, maybe answer that question, if folks are interested in joining the movement and working with us in advocating for that type of legislation, we're more than happy to work on that with you. So thank you so much. We are about 5 minutes over. Thank you for sticking with us and for that rich discussion. If for some reason we were not able to answer your questions today, this next slide includes ways that you can follow up with us. So please don't hesitate to contact us. The email address is there, connect@hepunited.org. If you would like to get in touch with any of our presenters, we would be happy to connect you. And lastly, I wanted to thank you so much, Dr. John Ward, Christy Chung, and Dr. Cami Graham for joining us, taking the time to share your work with us. Thank you, everyone, for participating. As soon as you close out the webinar, please be on the lookout for a brief survey to let us know what your experience was, any technical issues you may have experienced, and any further questions that you may have. We will be sure to follow up with you. And thank you again, and have a great day. Thanks, guys.
Thank you.
Thank you.